Good night, or good morning for different parts of the world. It gives me a great pleasure to be with you for this or in this very important webinar of point-of-care ultrasound, which we are doing this series of webinars to introduce the point-of-care ultrasound in acute care settings fellowship, online fellowship. Contributing with faculties and societies from Sono School and Saving Lives Academy, and we have a lot of experts from all over the world. This webinar is full of rich materials that is related to point-of-care ultrasound and the updates about the planned program of point-of-care in acute care setting, point-of-care ultrasound in acute care settings. It gives me a great pleasure to co-moderate this webinar with Professor Orfa Shakaroun from Tunisia and Professor Jacobo Bacariza from Portugal. We are very honored to have three speakers, very well-known international speakers, Grace, Daniel Lichtenstein, Walid Al-Habashi, and we promise you that you're gonna hear a lot of updates about the point-of-care ultrasound fellowship and the way and how to register for this online program. It's not only online, but there are a lot of other updates that you're gonna hear today from Walid Al-Habashi. Professor Olfa, the mic is yours, and please introduce the first speaker, but let me just give you a brief about the program of today, which is the introduction I already did. We'll start with Grace, and then Daniel Stein, then Walid Al-Habashi. We'll have a good time, and we try to answer all the questions needed. And just reminding all of you that the next webinar would be May 15, and the one after would be June 10. And you can contact us for anything related to this program, either by visiting wiccem.org, the umbrella of all of these activities, or WhatsApp me or email me on this, what you find here in contact. Olfa, I will stop share and you please introduce Grace.
Thank you. Hello, everybody. I have the great pleasure to be with you this afternoon, and I'm pleased to present our first expert speaker. She is Dr. Grace 𝐏𝐿. She's an assistant professor of emergency medicine, and she's at the Albert Medical School Brown University. She's an expert in creating and researching and evaluating POCUS in low and middle-income countries. So we have the great honor to have Dr. 𝐏𝐿 with us to talk about POCUS in low and middle-income countries. The mic is yours, Doctor.
Thank you so much. Thank you so much, Doctor, for your kind introduction. I'm going to just take a minute here to share my slides and hope that those are coming through fine.
It's okay.
Thank you so much, Dr. Olfa. Thank you so much to my colleagues for the opportunity to be here today. Once again, my name is Grace 𝐏𝐿. I'm an emergency physician. I am originally from Kenya. So I currently work in the United States, but I do a lot of my teaching and research in Kenya, where I am originally from. So some of this work the experiences that I'll be presenting here today will be based on my work in Kenya. I have no conflicts of interest to declare. The first case that I will present to you happened at this hospital. So this is Kenyatta National Hospital in Nairobi, Kenya. It is the largest referral hospital in Kenya. They receive referrals from all over the country and all over the regions really in East Africa. It's about a 1,600 patient bed hospital. It is publicly funded, so chronically underfunded, chronically low resource setting. So this case happened at the beginning of the COVID epidemic. This was early in 2020. This gentleman came in complaining of shortness of breath. These were his vitals. His blood pressure was on the lower side, but normal. He was tachycardic, tachypnic with a respiratory rate of 30, and his saturations were about 89 to 90% on room air. So as was the practice at the time, pending evaluation and pending the return of the COVID test, the patient was placed in the isolation unit. And while he was in the isolation unit, the blood pressure started to fall. So this patient deteriorated in the isolation unit, blood pressure 80/55, respiratory rate 40, saturation, they did not, at the time, they could not tell what the saturation was because the probe, the saturation probe has broken down. So they called the ICU to come and evaluate this patient for possible admission to the critical care unit. So the doctor from the ICU who came in had just received very basic training in point of care ultrasound. Nothing complicated. This is just a subxiphoid view of the heart that they obtained at the bedside, illustrating that on the subxiphoid view, we have the liver anteriorly and we have the heart here, and they revealed that this patient had a pericardial effusion. So what the resolution of this case was that the patient underwent an emergency pericardiocentesis, the vitals normalized, they no longer needed to go to the ICU. And in a low-income country, and even in high-income countries, ICU beds are limited, always at a premium. And so if you save the need for a patient to go to an ICU and ultimately saving this patient's life at the moment, that is a major win that was made possible by the performance of bedside ultrasound. Unfortunately, the patient was diagnosed, the fluid was diagnostic for non-Hodgkin's lymphoma, but at the very least, they were able to be diagnosed and connected to the oncology team for further care. The next case is a very recent one from a very recent trainee working in a county hospital in Kenya. So they are not in a referral center or anything. They are working in a small county hospital, but they just received recent training actually in February of this year. A 23-year-old female came in complaining of abdominal pain, vaginal bleeding, and they were hypotensive with a blood pressure of 84/43. They were tachycardic, basically unstable at that time. So our trainee, and I'm trying to present these cases as a bit of an encouragement that even with basic ultrasound teaching, it can really make a difference in the trajectory of the patient's care when on the front end, when they come in, when you're providing acute care. So our trainee, who is not a physician, they are a mid-level provider, so they are a clinical officer, sent off the blood work, they resuscitated this patient, but instead of waiting for the results to come back, they went ahead and did the point of care ultrasound. So this is just a picture representation of a sagittal view of the female pelvis with the bladder located here. We see the uterus here. We see the endometrial stripe, but we do not see anything. There's no intrauterine pregnancy. What we do see is a lot of dark free fluid here surrounding the uterus. And once again, I'm going to play this video. This is a transverse view of the same patient's pelvis. I apologize that it's not as deep as it should be to capture everything, but we see the free fluid here. You see the uterus coming in its transverse view, the endometrial stripe, and there is no intrauterine pregnancy, but there is a lot of free fluid around the uterus. A trainee went ahead and obtained a right upper quadrant view of this patient. And what you see here is the liver, you see the kidney, and there's a stripe of free fluid where it shouldn't be in the right upper quadrant. Same thing in the right upper quadrant. They're interrogating the inferior pole of the right kidney and visualizing free fluid there. So what this patient did is that once our trainee saw that on the front end, while they were resuscitating the patient, they were also calling the GYN team to take this patient to the operating theater. And that's what happened. So by the time they got the pregnancy test back to know that this is a ruptured ectopic, they already knew based on the ultrasound, and they already knew that this patient is going to need to go to theater. So this is just a representative picture, but another case of an 18-year-old male coming in after a car accident with diffuse abdominal pain, also blood pressure low normal on arrival. These blood pressures tend to, these patients tend to just, become hypotensive, become very sick very quickly. And once again, on the ultrasound, they were able to see that they had free intra-abdominal fluid. So there's a study that came out in 2013 by Dr. Razak, which showed that 50% of all global mortality is caused by emergency medical diseases, right? And unfortunately, in low and middle income countries, the burden is 4 times higher than high income countries. So people, us in low and middle income world, are shouldering a very heavy burden of emergency medical diseases. The disease control report, disease control priorities report also showed something similar, that 54% of all deaths in low and middle income countries could be prevented by effective emergency care and by extension, effective critical care as well. However, the WHO came up with this statistic that 2/3 of the world lacks access to diagnostic imaging, right? And this is the statistics that we're trying to reduce. This is the disparity that we're trying to deal with point of care ultrasound. So when we talk about access is a very interesting, we kind of have to interrogate that a little bit. What does having access mean? So the first case that I presented to you happened in Nairobi. This is a picture of Nairobi, Kenya, right? This is a large metropolis in Eastern Africa. It's, you know, a busy, bustling place. It doesn't look like the idea of what you think about when you think about low or even middle income country. However, at Kenyatta National Hospital, the public hospital, I rotated there 2018, 2019 before the pandemic. There were 2 portable ultrasounds for the entire hospital, 1,600 bed hospital. That means that if you need portable ultrasound, you could be waiting for up to 48 hours in the ICU, in the emergency department. You could be waiting for a long time. And so if we think about access as the right patient getting the right study they need at the right time, I actually think the statistics is even more dire. We really do not have access to diagnostic imaging. And then this is, you know, the other extreme of that. And this is a small clinic where I trained 2 nurses who work here. We trained them several years ago. And at the time we provided an ultrasound to them. They didn't have any other means of diagnostic imaging. So access, when people think about low income countries, they think about the small clinic. But once again, even in large hospitals, do we have the imaging we need at the time that we need it? So this is where point of care ultrasound comes in, because it allows us to do rapid diagnosis. There's studies that have shown that it increases diagnostic accuracy. It leads to patient satisfaction because you can take care of them, you know what's going on with them earlier. And as technology advances, we now have more portable, more cost-effective machines that are coming up that makes it, you know, it's more cost-effective, it's cheaper for us to purchase, it's easier for us to take it to these areas that are, you know, geographically isolated, resource-limited regions. Once again, this is also a teachable skill. You know, it's not only for doctors, it's for nurses, for mid-levels, for paramedics, for people who work in the pre-hospital world. This is a teachable skill that can allow people to save lives and for us to democratize diagnostic imaging. I just wanted to go through this. This is a study that we published last year, talking about, I've spent several years in Kenya teaching people who work in rural areas on the use of point of care ultrasound. And we were trying to figure out, how does using ultrasound help them with the decision whether to keep the patient in their small facility or whether to refer them to a larger hospital. And the issue of referral is a big one in low resource settings because of the resources that you have to put in place to complete a referral, right? If you can take care of a patient in their home versus do they have to pay for an ambulance? Do they have to go pay for a new doctor, pay for new diagnosis at a larger hospital? So if ultrasound can help you kind of refine that process, that's the question that we were asking them in this qualitative study. So I'm going to, before we did it, we did a survey to look at these facilities and look at what kind of capacity they have for patient care. So ultrasound, about 33% of them said they had an ultrasound in the radiology department. But if you don't have a radiographer at night or over the weekend, there's no access, right? X-rays, 48% said they had X-rays, but these break down all the time. CT scans, you know, very few of them had. MRI, you know, forget it. There's nothing. So then we did this interview and we were kind of trying to put the themes together. And what we found out is that the Institute of Medicine describes 6 domains of healthcare quality. For you to say that you're giving quality care, what does the care have to be like? It has to be safe, it has to be timely, it has to be effective, efficient, equitable, and patient-centered. So what I'm going to share with you is what these POCUS trainees told us, the quotations, specific words from their own mouth, which illustrates to us how point-of-care ultrasound helps them to get to these 6 domains of healthcare quality. So when it comes to safety, one doctor says, a patient came in with low abdominal pain, and we had a resident sonographer, but he was not in. And so I had to do point-of-care ultrasound, and we found that there was free fluid in the pelvis, and we had to refer this patient outright because we don't have a theater in our own facility. So what I didn't say actually on this presentation was that these facilities, they're small facilities, they're out there. They admit a lot of them say that they have wards where they admit patients. So they admit pregnant women, they admit, they have a medical ward, they have a pediatric ward. But if a pregnant woman who's admitted needs surgery, very few of them have the capacity to perform a C-section or have the capacity to perform general surgery. And so it becomes a major safety issue. You have to know, is it safe for me to keep this patient here, or do I have to send them out? Trauma cases also, it's important because you might delay the patient, especially if there's a hemothorax, internal bleeding. The more you stay with the patient, the more you might lose the patient. So ultrasound has really helped us in terms of the referral system to make decisions very fast. Once again, I was interviewing one of the doctors and I asked them about a specific case we're talking about. And I asked him, how would you have managed this case if you didn't have an ultrasound? He said, without the ultrasound, I would have sent her to a radiologist to make a diagnosis, have the imaging done, come back with a result, and then from the results, I would refer them. So there's a back and forth that is involved with the traditional model of providing care. So I asked him, how much time would it take for the right diagnosis to be made? And he said, it could take roughly a whole day, even 2, depending on the readiness of the patient, because sometimes financially they're not able to. So they will tell you, let me first go and get finances. It can take a whole month. Sometimes you even lose a patient. What he was saying is that if the doctor sees a patient, says you need to go get an x-ray, they have to go pay first. They have to go line up at the cashier, pay the money, and then go get the receipt, go and stand outside the radiology department, wait for the x-ray to be done. So first of all, if they don't have the money, they will go back home first, right? To try and look for the money to come back and get an imaging. So we have significant issues in low resource settings that point of care ultrasound can help us deal with. This is a trauma case where I was asking them, if you didn't have an ultrasound, what would you have done? They were saying that ultrasound helps them be more efficient. The fact that it was revealed that there's internal bleeding, of course, that one will put people on toes. This is not a light matter. It quickened or it helped people to understand that this is a real emergency. The service or the attention changed pace. I won't go through this one again, but this is how they were explaining that the use of ultrasound helps them to reduce diagnostic uncertainty as well. So you can tell the patient exactly what's going on. The use of point-of-care ultrasound at the bedside also helps provide equitable care. Because our point-of-care ultrasound, we don't charge anything, we just do it. It helps us to reduce the cost because once we send them outside, they have to pay. The use of point-of-care ultrasound helps with patient-centered care. There are some patients, maybe they've involved themselves in a serious accident and they cannot be moved in an easy way. The portable ultrasound helps you to go and just perform it right at the bedside. It is easy to just come and do the scan at the bed there. So sometimes this picture I put here was this is at Kenyatta National Hospital as well. The ICU is on the 7th floor. And if you need to get a CAT scan on a patient, maybe, they change or they're having a hard time ventilating them. There was no portable ultrasound. There was no portable ventilators at the time when I was there, meaning that you have to disconnect the patient for the vent. You have to bag them down the elevator 7 floors for them to go and get a CAT scan, as opposed to you can do your ultrasound at the bedside, figure out, is it pulmonary edema, is it pleural effusion, is it pericardial effusion, what is it that's going on? It allows you to troubleshoot at the bedside, and that is a big deal. So those are just some of the cases that I wanted to present and some of the information. Hopefully that this is more of an inspiration for us to keep doing this and to keep training more people. Please email me if you have any other questions, and I'm happy to take questions on this forum as well.
Thank you very much, Prof. Grace, for this very nice presentation. We just have a small modification in the program. So it gives me a great pleasure. Of course, Grace will introduce the questions. Alpha and Jacobo will handle the questions to you at the end of the meeting as we decided before. We just have a small modification of the program. So we will present now the presentation of Dr. Walid Al-Habashi. And as we all know, Walid Al-Habashi is a consultant of anesthesia and ICU in Dorset County in United Kingdom, with a long experience in both anesthesia and ICU, and of course in point of care ultrasound, running courses for decades now. And he is the owner and founder, director of one of the academies that is very actively engaged in education, present education or online education. Walid will speak to us now about the updates of our target, which is the point of care ultrasound in acute care setting fellowship, online fellowship. So please share the presentation. And Walid we are very fortunate that he is online with us. He is very busy covering the IC now, but hopefully he will be with us for any question till the end of the webinar. Again, the question will be at the end of webinar. We'll listen now to the updates.
Good evening, everyone, and welcome aboard. My name is Walid Al-Habashi, and I would like to invite you to the Point of Care Ultrasound Fellowship in Acute Care Settings, which is an online fellowship extending over 48 weeks. Tonight, I'm going to update you on the program overview and what we had settled on to use for the coming 48 weeks fellowship. So in this program, we'll go in depth about all high-yield topics used in critical care and emergency settings, and even for other medical subspecialties. In the first half of the program, which is 24 weeks, we will be covering the basic and general topics of importance to all different specialties. We named it the common pathway, which will be covering the basics of ultrasound like physics, echocardiography, the basics, lung ultrasound, the basics, focused assessment with sonography for trauma patients fast, inferior vena cava, DVT, shock management, and even more. The last 2 weeks of this 24 weeks will be assigned and entitled for exam. You need to pass the exam after this 24 week. Then you will pick one of two pathways of the specialized pathways. You can either recruit yourself into the emergency track, which is designed mainly for the emergency ultrasound physicians. This track is 24 weeks, covering pediatric ultrasound, musculoskeletal, nerve blocks, and other specialties. Or critical care track, which is advanced echocardiography techniques, focused cardiac ultrasound for intensivist, transesophageal echo, advanced echo for ECMO cannulation, fixed score, and more. And the good news is the program will be released very soon, so you can have a look and decide which pathway you can select for yourself. The program is characterized by focusing on clinical settings. Yet we have certain privileges to be in this program. First, it's a flexible learning style. So you have an access 24/7 asynchronous audio-video lectures. So in your own time and pace, every week you will find video lectures that you can open and view online on your own time. It's all clinically based teaching. It will also include case-based studies for practical application of ultrasound in real-world scenarios. We'll also have journal clubs on every week for in-depth discussion on the latest research and advancements in critical care and emergency settings of ultrasound. As I said, it's all about real clinical scenarios. No theory of big depth in this program. Every 5th week, there will be a live webinar. In these live webinars, you will meet renowned international speakers and experts to have in-depth discussion and reflect on your practice to reach the benchmarking level of critical care ultrasound. It's a global faculty coming from different areas in the world. So more than 30 speakers from United States, Europe, United Kingdom, Middle East, Africa, to set the cutting edge of internationally recognized program. I strongly advise you to have a look on our website, WICCAM, in collaboration with Sono School and Saving Lives Academy. We created this program. Director of this program is Dr. Ashraf Al-Tayyar. Myself is the academic director of the critical care section, and Dr. Wissam Ibrahim is the director of the academic section of the emergency section. This is our scientific board: Dr. Xavier Monet, Dr. Haytham Khalifa, Dr. Grace Wanjuku, Dr. Magid El-Warraqi, Professor Michel Slama, Dr. Hisham Faisal, Dr. Sylvia Mungodi, Dr. Muhammad Nasruddin. Our faculty is Professor Daniel Lichtenstein, the father of lung ultrasound, Dr. Ahmed Higazi, Professor Kira Ruba, Professor Daniel Antoine Villar-Barou, Dr. Nevisha Barag from South Africa, Dr. Abdul Hamid Nouruddin, Dr. Thamir Al-Aifan, Professor Michael Lanispa, Dr. Muhammad Rashwan, Dr. Hisham Timraz, Dr. Muhammad Bulad, Dr. Muhammad Magdadi, Dr. Liqa Rafi', Dr. Ulfa Walha, Dr. Amr Abu Al-Ala, Dr. Salah Imtiaz, Dr. Omar Jaradat, Dr. Muhammad Abbasi, Dr. Hazim Musa, Dr. Muna Surur, Dina Magdi, Ahmed Salman, Islam Naeem, Amgad Makhur, Ahmed Al-Sanusi, Haytham Khalil, and plenty more. You can contact Dr. Ashraf Al-Tayyar at ashrafaltayyar@wiccm.org if you have any clinical queries about the program, and if there is any administration issues, you can contact Habiba Muhab at wiccm or icomgroup.org. So I would strongly advise, if you are interested in this program, to press register now. So the registration is currently open, so you can put your name and your details, and you will immediately get an email once the payment starts. The registration now is open. You can start registering, but you are not going to pay straight away now because the payment is not ready yet. This is an example for the virtual hands-on simulator website we are going to use which is Mr. Timothy from MST company. So you will get a hand-on experience on real models, real cases of transesophageal echo. We had settled an agreement with MST company now, and you will be allowed to put your probe in using your hands-on technique virtually. So you will push the probe in and out. You will do the anti-flexion, retroflexion, everything you can do on Mr. Timothy online edition under our supervision. So we'll guide you what to do and how to do in 10 different clinical cases or more. That's in the advanced section of critical care echocardiography. Another simulator will be happening in obstetrics and gynae as well, in the emergency section. And we will update you in May, in next webinar, what simulator we are going to use. Accreditations, we are working currently on different accreditations, but at least what is granted is the American Association of Continuous Medical Education, but we are working with different societies to get approvals for this program. What's in it for you? You will get certification like the fellowship. If you would like to extend beyond the fellowship, you can do the diploma. The diploma will include one of hands-on courses, which is approved by big institutions like American Society of Critical Care Medicines, European Society of Intensive Care Medicine, our courses in Saving Lives Academy, which is happening in 5-6 different countries, or the same as with Sono School. Then you can use our mentorship platform. Again, you will be monitored by one-to-one mentor, and your exams will be reviewed, and you will be advised how to properly do the exams, and we will accept or reject these cases as per one-to-one discussion. So you will be assigned for an international mentor and supervisor who goes through your exams one by one and advise you if they are correct and fulfilling the criteria or needs to be improved.
I think because
Full meal, fellowship, theory and practice guidelines. So you are up to benchmarking, and then you attend the hands-on course, and then you do 50 cases on your own with a remote mentorship via Saving Lives Academy or any other platform you are interested in, if you can secure a mentor or supervisor for yourself. This is an example of Saving Lives Academy mentorship, and these are exams uploaded by one of the trainees. So you can upload your exam here, and then your mentor will be accepting or rejecting this exam. So you can upload all the image and videos, and there is anonymization methodology. So if your exams are not anonymized, you will find during this platform, you can anonymize the patients to keep as per GDPR guidelines. So your mentor will have a look and accept this exam and have a discussion with you virtually. So it's all under one tent. So mentorship is different and separate from this fellowship. So you can do fellowship or diploma. It depends on what your needs are. And fellowship is by WICCM. And after that, you decide if you would like to go ahead with any other extensions as courses, as hands-on courses, and as per mentorship. Thank you very much for listening and keeping following. And if any questions, Dr. Ashraf Al-Tayyar and the team are happy to answer. Thank you very much. And for an apology that I am not able to attend physically today because I am on duty. Thank you very much.
Thank you very much for this nice updates by Walid Al-Habashi. And I know there are a lot of questions about the link for registration and payment and how much it costs. This will be announced by Dr. Amr Al-Husseini the president of �WICCEM, right after Dr. Daniel Lichtenstein. Jacobo, mic is yours to introduce Professor Daniel.
Hi, good afternoon. My name is 𝐏𝐿𝐒𝐿 I'm a specialist in intensive care medicine and internal medicine, currently working as a senior consultant at the intensive care unit Hospital Garcia de Horta. Is one of the central university hospitals on the south side of Lisbon City. I'm also board of the WICCN, and today I'm going to be one of the moderators of this webinar. We have here a special doctor which needs no a presentation, because pure and simple we're talking about the father of the lung ultrasound. I'm not only talking about a teacher or a mentor, but also a friend and a unique doctor that really changed dramatically the POCUS reality. I could spend the whole day, even the whole week, talking about him, but of course we don't have that much time. So with any more delay, let's move on the next talk, delivered by the Professor Daniel Lichtenstein. Professor, the mic is yours.
For this invitation, I opened the chronometer for a 20 minutes lecture. I will try to be before. Lung ultrasound in a clinical practice, basis for being integrated into the SURF fast protocols like Blue, Folds, and Sesame. It's a, I do not push the right button. Of course, the slides do not move. Okay, so this invitation is a great honor, increasing. I have no conflicts of interest. These slides are propaganda. I will say, okay, not supposed to exist, new standard of care, nice promotion. It's propaganda, we lose time. So lung ultrasound in the critically ill is LUCI for saving time. This impacts the definition of ultrasound. Of course, the slide do not move. Zoom is not a tool, it's a humbug. It changes medicine, it changes the physical examination, blah, 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 but it is not our contribution. The lung is even not in my first paper of 1991, which described whole body ultrasound for the critically ill by the critical care doctor, not only the lung. The lung is only a cherry on my cake. And this cake is called critical ultrasound. And I want that the community says, not, he published on the lung, but who was before? Somebody in 1991. Okay, so I wanted to say, okay, I say that because I will say the opposite of what is said by the experts. And I ask your understanding, because maybe I began before, maybe I know more things because time is just time. And we are already late. So lung ultrasound, because you asked me to speak of lung ultrasound, is not very, very easy. It is easy, but there are many things that needs to be understood one after the other, quietly. And this is my work currently, that is avoiding to complicate a science that is a bit subtle, a bit complicated, but let us not make it more complicated than it is, and let us clean all the points that are wrong, illogical, confusing, completing, inesthetical. And this is, I told you, my new job. And it makes an acronym. Wiki is not WICEM, it's Wiki, not far. And so the wiki side of LUCI is dealt with in this recent commentary. And take your time for reading it, there is no emergency. For making the Blue protocol, what do we need? A simple machine. This machine was available in 1992 or even the ADR before, 10 years before. This machine couldn't go in the poor world. Last century, one probe, universal for the whole body. Here again, we can make dramatic savings. This probe, it's a microconvex probe, is the best for the lungs. And if you want to make heart, but look, there is a heart, and there are three visions of the heart with a probe which is not a cardiac probe. Look the image quality of this lung, very diseased. Downstairs, look at this beautiful, if I can say, deep venous thrombosis. And if you want to see the heart, you put the probe facing the heart and you see the heart. There is no mystery, it's terribly simple, and one probe imaging the savings. Where to apply the probe, I make very short to these two anterior points, and if needed in the blue protocol, to this posterior point, which I have no time to. Next slide. The acquisition is the most important step of ultrasound, any ultrasound, and we must acquire this image in a rib short axis, which we have called the bad sign. And for making the correction of the anatomical asymmetries, we need 3 maneuvers. Each one is simple. And we can attack the 10 basic signs of Lucy. It will be for beginners, but also for experts. I'm sorry for that, we have no time. I have the microphone, so I can express the voice of surf. The first of the 10 signs is the pleural line, which makes, as you can see, something like a bat, so we called it the bat sign. And this is the pleural line that always indicates the parietal pleura, always. The second sign is the A line, and you can see here a repetition of the pleural line, indicating that below the parietal pleura, there is gas. The third sign is lung sliding, which will appear in the frame that we called the Merlin space, limited by the pleural line, the shadow of the ribs, and the depth of your image. I take off the frame, and we can see this sparkling of the whole of the Merlin space, beginning exactly from the pleural line. Lung ultrasound is the gold standard, and it indicates that the gas below the parietal pleura is alveolar gas. There is no pneumothorax and other important informations. This is a demonstration of lung sliding using a very intelligent machine, because the two images are exactly side by side, and we can see the seashore sign showing the millimetric appearance upstairs. Okay, it's not in the slide, I have no time. Doppler is absolutely unnecessary for this and for the rest of lung ultrasound, and even for critical ultrasound. Very fast pleural effusion. The sign at surf is the quad sign that is limited by the pleural line, and downstairs, where is the line, the lung line, it makes a quad, and we call it the quad sign, and no time for speaking of the sinusoid sign. A highly specific 97 is 100. No Doppler, of course. Lung consolidation has one unique name, which is the fractal sign. Here we have a partial consolidation, subpleural, of course, and we can see the fractal pattern of the image downstairs of the image. And when the patient has a big consolidation, there is, so to speak, a maturity of the fractal sign, because we can see the whole of the lung, which is completely pathologic. You cannot see 1 millimeter square of the lung, and here you can see the whole lung. This is why we called this sign the lung sign. It is a fractal sign that got full, and both cases are lung consolidation. No need for Doppler. The B line and the lung rockets. This is a B line. 7 criteria. I remind them, it's always useful. First, it's a commit tail, but not only. It is not the commit tail. This commit tail artifact arises exactly from the pleural line. This commit tail artifact arising from the pleural line moves with lung sliding in patients who have a lung sliding. Of course, we have to specify. And this comet tail rising and moving is long, does not fade. That is, I take a long one. You can see it makes 10 centimeters or more. And it has an optical range. That is, it could reach a march of Jupiter. So long is upgraded in the always present criteria. And almost always, very rapidly, almost always, so we come back to the previous image, it is well defined, like a laser. Almost always, it obliterates the A lines that should be located exactly here and here. And you can see the B line is dominant, dominates the A lines. And the last criterion is hyper-echoic, that is white like the pleural line. More than 2 B lines in the rib short axis, more than 2 B lines like here, are called lung rockets. And lung rockets indicate interstitial syndrome period with full accuracy since last century. Pneumothorax and the A prime profile. This is a basic view without any comment, and we will comment them. So we are anteriorly, of course, we must follow always the gravity, principle number 2 of Lucy. Now we will comment them, of course, no need for Doppler. Here I put the video, I'm not sure, no, yes? Yes, there is the video, but the image is completely static with the video, and we can see abolition of lung sliding, making at the right on MO the stratosphere sign, please not barcode.
Recording in progress.
Can I go on?
Of course, Professor, of course.
I have only 10 minutes. Why is that voice interrupting us? Okay, I go on.
Keep going. Don't worry. Keep going.
So this is the stratosphere sign, please. And you can see A lines and never something else than A lines. It is a constant sign. And of course, at the peak area, that is anterior wall in a supine patient. And this sign is fully sensitive for pneumothorax. Not specific, but fully sensitive. For being specific and quietly inserting your needle in this critical ill patient, we wait one more sign, which is the last of the 10, the lung point. Here is a typical lung point. I will save time by being very short on this slide, fully specific. So in this 20 minutes lecture, there will be not one word, there was not one word on the longitudinal or transversal or oblique scans, which makes no sense. Subpleural consolidations, they are all subpleural. Tissue-like pattern of pneumonia, we don't use it. Thickened irregular pleural line, we don't use. Spine sign, curtain sign, we don't. Coalescent B lines, we say glass rockets, indicating ground glass lesions. Alveolar interstitial syndrome, what? Ultrasound can see alveolar or can see interstitial, but not alveolar interstitial. ARDS, I don't know what it is. The loose is the lung. Ultrasound score for even burned in the stone. In the peer review literature, onion ring sign, snow sediment sign, waterfall sign, peanut sign, rhubarb sign. There are millions ways to complicate simple signs. Diaphragm, physics of ultrasound, fast protocol, vascular probes, interstitial artiligence for counting the B lines, etc., is not at surf. Really not at surf. We don't speak of all that. It is complicated enough, to my opinion. So now we'll see the dyspneic patient, or even more, because we make a lecture on how we should use ultrasound. Why? It's no longer a question. We are always surprised to hear doctors explaining in 2025 why to use ultrasound. I have no time to make propaganda. Maybe I am wrong, maybe they are right. After 36 years of research and development, this lecture will be fully with the how. So how to make exist science not supposed to exist. Let us see respiratory failure, an example of the blue protocol in a special patient who came from esophageal surgery, comes in our medical surgical ICU with a poor saturation. And we have this. So we make echo, of course, that is echocardio. And in this patient, there is no cardiac window. It happens. And the classical option that you all would do, that is a transesophageal one, is impossible. What do we do? What do we do with this lady? And by the way, how was the cardiac window? What did we see? Here at the left lung. We saw this. And we have the answer. Lung rockets, lung sliding. This lady has a B profile at the 4 anterior points. That is a priority diagnosis of hemodynamic edema. And the final diagnosis was fluid overload. Next patient. And in this example, Lucy was clearly superior to expert Doppler echocardiography, even transesophageal. Blue protocol. A cardiac arrest in the ward. So we will see the Sesame protocol in one slide because time is running. We rule out shockable causes, of course, we are normal doctors. And lung first, heart last. We scan the lung. If we do not see this pattern of a pneumothorax explaining the cardiac arrest, we go to the second step. See the number 2 is a specific vein above the knee. This is a thrombosis that clearly indicates the cause of the cardiac arrest, unless I should change my profession. If we do not have a patent vision of a venous thrombosis, we go on the Sesame protocol and we go back direction to the heart. This is a small collection above the liver, but this is the iceberg sign. We are in the Sesame pouch. This indicates the cardiac arrest was hypovolemic by bleeding, I suppose. If not, we come to the heart. I make fast with that image. We rule out that there is a pericardial anomaly. And then the only thing that we have to do is sadly to see the heart itself. And usually all the diagnoses that we will make that were not made at the steps before indirectly will be disappointing for the prognosis. I wait questions because we are very short. If the cause of the cardiac arrest is pneumothorax, Lucy is without any discussion superior to the echocardiography increasingly advocated in cardiac arrest. So this is an acute circulatory failure. So no time to read the story. That's a young man in shock, carbonates. The false protocol takes first a look to the pericardium, dry, not the problem, but 1 second, dry. Second, we see that the right ventricle is not dilated, so embolism is unlikely. You all see that the left ventricle has an excellent contractility, but it is not in the false protocol. Please ask questions. Instead, we look at the lung and we see there is a lung sliding, so no pneumothorax. It's not the question, but it takes 1 second. And the A line is visible. This patient has the A profile. The pulmonary artery occlusion pressure is below 18. We can give fluids. There is no obstructive shock. There is no cardiogenic shock from the left origin. We can give fluid. And the patient had, by the way, a deep hypovolemia. I go very fast. So Lucy was done just after our holistic cardiac sonography and gave immediate independent on-off data. A few seconds, yes. Whew, a few seconds. So the blue protocol, it's physiology in 1 sentence. In a dyspneic patient, the SURF chooses and suggests and advises the right target, which is the lung, because the patient is dyspneic, the lung before the heart. the philosophy of the false protocol in one sentence. For once, we have an approach, I don't know another approach without the slightest numeric value. The only point is the change from an A profile to B lines. That is the sentence of the false protocol. And the Sesame protocol, its philosophy for the wealthy countries and also for those who have no time to change or to buy probes, when each second matters, choose the holistic ultrasound with a machine that starts done in 7 seconds, 1 single probe and the lung first target. And at SURF, the lung and the blue protocol make 78% of our program, and we finished before 20 minutes, in spite of all the hindrances that came in this lecture. Thank you, and I hope there will be questions and comments, or any comments are welcome. Thank you.
Thank you so much, Professor, for this absolutely wonderful lecture. Without knowing, you are answering already a lot of the questions that they are on the system. If you want, we can move on with the next step.
𝐏𝐿𝐻𝐒𝐿, if we just give 1 minute or so to Dr. Amr as we planned. Amr Al-Husseini is the president. Before we go to the question and handling the question, kindly allow me, Olfan Jacobo, to introduce Dr. Amr Al-Husseini. Thank you very much, Prof. Daniel, for the nice presentation as usual. Amr Al-Husseini is the president of WICCEM, the umbrella of these fellowships, including the point of care ultrasound in acute care setting. Amr kindly will present us the way how to register and the way how to pay for this online fellowship program. Mike is yours, Dr. Amr.
Thank you so much, Ashraf, and it's my pleasure to introduce to you this fantastic, wonderful fellowship, the first of its kind in the whole entire world. And as the president of the World Institute of Critical Care and Emergency Medicine, I assure you that you will have very high quality fellowship program. And we also have 2 very well-known international focus-oriented organization, the Sonos School and Saving Life Academy, and we are also very proud of this partnership. Here you will see the program landing page. I'm also very sure under Dr. Ashraf At-Tayyar mentorship and under Dr. Walid Al-Habashi and Dr. Wissam Ibrahim academic directorship, you will have very competitive and strong scientific materials, and also all respect to all of our international board member and faculty. If you go down here in the landing page, and by the way, I put the landing page links in the chat box. If you are interested, you can copy these links. So when you click, if you are interested to join this 1-year fellowship program, you can click here on the registration page. This will take you to this registration page. You need to put your name, your email address, your phone number, your specialty, working place and occupation. Then you click submit, and after you click submit, you're going to receive this submission confirmation and notification, and you need to click here, click to pay, and this will direct you to the last step in the application process, which is the payment. Again, you need to put your name and email address, verification, your specialty, your mobile number, and your country. Then here is the tuition fees. So I need you to focus on, for now, mainly 3 options. You can pay for the first 6 months, which is a common module, the common pathway. So that's 6 months of training. And the tuition fee for this common pathway, whatever your specialty or subspecialty is, you can apply here if you have a promo code, and I'm very sure that Dr. Ashraf is going to share with you right after I finish a common discount promo code you can use to get, I think, 15% discount. So you can add the promo code here. So instead of paying 620 for the whole 6 months of training, you will be paying 500, whatever, 60 or 70 after the 15% discount. Then, if you want to do the full year, if you are ready to pay for the full year, you just need to identify your full year specialty. Do you want to go with the critical care? Then you can get extra 10%. So you'll be getting 15% from the promo code that Dr. Ashraf is going to share with you. Then you are going to get another, an extra 10% if you pay for the whole package, the 1 year fellowship program. If you are critical care, you can click here. If you are emergency medicine physician, you can, or if you are interested in any of these routes or pathways, you can choose which pathway you want to choose. Then you get 10% on top of the 15%. Again, we welcome you to this very competitive training program. And I will give the microphone to Dr. Ashraf to give you the promo code and more information. Then we can try to answer your questions and concerns.
Yes, thank you, Dr. Amr, for this very nice presentation of the webinar links, the fellowship links. And the promo code is 15%. There is discount for 15% if you early bird register within this month. So it ends on April 30. Habiba will share with us very soon the code. I don't have it currently now. So Habiba, if you have it, just put it in the chat. But there will be another promo code for both Saving Lives Academy, 15%, and the Sono School, 15%. There will be discount of 25% for group administration or registration. Group of 10 or more will get 25% discounts. The code itself, I don't have it now. Till we prepare it, maybe within the next few minutes, let's go to the discussion, and this will be moderated by Jacobo and Olfa. Olfa will start.
Dr. Ashraf, Habiba
Yes.
put it here, it's early 15. The
So
promo code is early 15 to get 15% discount.
Okay, EARLY 15 with no spaces will give you 15%. Thank you very much. Discussion time, Dr. Alfa.
Thank you. So we have some questions we can discuss. The first is how to differentiate cardiogenic and non-cardiogenic pulmonary edema by lung ultrasound. Dr. Lichtenstein is with us?
Blue protocol is answered in 2008 and even before. If you make the blue protocol, you will see in most 97% of cases, hemodynamic edema, you will have the B profile. In the inflammatory edema, which I suppose comes from pneumonia, I call it extensive pneumonia, you will very infrequently have the B profile. Even never, you will have one of the 4 profiles of a pneumonia, because we search for a diagnosis of pneumonia, and we will have the B prime or the C or the AB or the AV PLAPS profile. Next patient. Since 2008, and you have even in the blue protocol the description of the COVID-19 pandemics. The article is here, available. Did I answer the question of the auditorium?
Of course, Professor. We have here another question, and they're asking, Ataki from Indonesia, which are the sonographic findings suggestive of pneumothorax in asthmatic patients? So pneumothorax.
Yes, I thank you for this question also. Which are the signs of pneumothorax?
No. How can we make the diagnosis of pneumothorax? Which are the sonographic findings for the pneumothorax?
What are the signs of a pneumothorax?
Yeah.
It was in the lecture, but I can repeat. No, the question is highly interesting, but it should take a lot of time, and I don't know our limits in time. But when we are in quiet conditions, the diagnosis of pneumothorax is abolish tongue sliding with A lines. Fully sensitive, not specific. We search actively where is the lung point. If we have the lung point, we can insert our needle if we want, if we need to. I have the opportunity to say that this is when everything is fine. But in the real life, when the patient is dyspneic, very dyspneic, it completely changes. And if you have a complicated machine that is 99% of the equipment in the world, you will have difficulties, major difficulties with some equipment. And to explain how the surf deals with the dyspneic pneumothorax would take a lot of time. It's not so simple. We need to do the things quietly. There is a solution in 90% of cases. The 10 other percent will still benefit from the clinical findings, X-ray for some, but usually we have the answer, but it's a tricky question. If we speak of the simple idiopathic pneumothorax, I showed the slides. There is nothing else to say for simplify. Did I answer correctly?
Yeah, of course.
Thank you. We have another question about focus in the context of cardiac arrest. How is it possible to perform a focus when we perform a high quality CPR, and what are the ethical implications of its finding in cardiac arrest?
Did I hear the word ethical?
Yeah.
Okay, it's again for me. Well, I'm sorry.
As you wish.
Or grace.
Or grace, yeah.
Ethical,
as you wish.
I will just say what I think of the word ethical. What is today ethical would be highly unethical tomorrow. If you use, this is what I write in the surf lectures, never use ultrasound in a cardiac arrest. If you use the traditional machines, equipments, probes, modes, etc. If you have the machine like this one, which is devoted to go rapidly exactly on site, the ethical problems will be disappear. How can you die from a pneumothorax? It is not accepted at surf. I don't go beyond because there would be a lot to say. It's a 1.5 hour lecture.
And how about the cardiac arrest? In the context of cardiac arrest, it will be for you or for Dr. Wanjiku if you want also. How is it possible to perform a focus in the context of cardiac arrest and its implication?
So I will say, I mean, I don't know if this is a complete answer, but I just will say in my experience in the emergency department, at least in the US, we receive a lot of out-of-hospital cardiac arrests, right? So EMS are doing their compressions, or sometimes they have the machine that is, doing the compressions, and, you're following your protocol and you're pausing every 2 minutes. When you do your pause, that's when I do my ultrasound. And a lot of times, especially if they have the machine, the mechanical machine that's doing compressions on their chest, the only access you have is the subxiphoid to be able to look at the heart at all. If you are performing CPR with your hands, then you can just have someone lift their hands, but really only do your ultrasound during the pulse check, which is a very limited time. you know. But I will say that there are some cases, because you have to add your clinical judgment to this as well. Because if you know that the patient has been down for a long time, if you know that they've been performing CPR in the field, you've also done it in the ER, you're following your protocols, it's been 45 minutes, you already know that ethics, it's complicated, and I'm not an ethical scholar too. But sometimes ultrasound supports what you already know, that if in that case you put your probe on and there's complete cardiac standstill, then it adds data to the clinical data that you already have, that you should terminate that resuscitation. Sometimes, and I have to, I'm not a specialist in this data as well, sometimes the ultrasound will help you, because there is actually data that shows that the pulse checks that we perform with our hands can be not accurate. So you do your pulse check, or you check here, or you check a femoral during your after 2 minutes when you're pausing CPR. You might not feel a pulse, but then you put your probe on and you can see that there's cardiac activity, right? So then that changes your algorithm, that you're not, that you have some cardiac activity. It's not futile. You can continue your resuscitation. So in my practice, that's how I use it. And I will say that this is not an exhaustive review of the data, but it adds to my clinical findings, and it helps sometimes when what you're feeling with your hand is really not is what is happening, that you can see that there's a heartbeat even if you don't feel the pulse.
If you allow me, Jacobo and Olfa, yeah, it's a very, very essential to know what you are doing it for what, and how you do it. And not redefining, but re-emphasizing or re-emphasizing on the definition of point-of-care ultrasound is a goal-directed, focused, goal-directed exam to answer certain questions in mind when you come bedside. And you do this in very shortest possible time to reach a diagnosis and to plan a care. I think, Jacobo, if you agree with me and Olfa, now we have to thank the two professors, Grace and Daniel. Daniel, you want to comment?
Will be extremely short, but I think the SESAME protocol was not fully understood. I just emphasize step 1 and 2 after the shockable causes. Step 1, pneumothorax, because it is not acceptable to die from a pneumothorax. So it is the priority first. And second, pulmonary embolism is solved for not at the heart, preventing the cardiac massage, searching for windows, sweating, but we search at a specific vein, which is thrombosed in 46% of cases. And so you can save half of the pulmonary embolism, and I make short.
Yeah, thank you very much again. Just emphasize on very important points. One is to mark your agenda for the coming webinar on May 13, and June 10. We have a lot of free activities, actually. We are not here for only to gain money. It's not a money game, but it is, as you know, everything needs money to run it and to conduct things. There is no free lunch in the world. Actually, and we are open for any suggestion regarding this. We are very open to help those from the low and middle income countries with all respect. And we have some scholarship. We'll offer a lot of discounts. We are open for any communication with us. We are here for our juniors and for our colleagues and seniors to make learning point-of-care ultrasound easy. So please, again, join the free webinars. And every 4 weeks of this fellowship, there will be a webinar, live webinar. We have WhatsApp group with a lot of activities every day. And we are open to mentor any candidate and to answer any question at any time you wish, my colleagues. So at the end of this webinar, I would like to thank again the speakers of tonight, Dr. Grace Wajunko, Dr. Daniel Lichtenstein, Dr. Walid Al-Habashi, and of course to thank Professor Olfa Shakuron and Dr. Or Professor 𝐏𝐿𝐒𝐒 𝐂𝐻𝐒. And the special thank goes to Dr. Amr al-Husseini, the president of WICCEM, who is doing a lot of efforts to make these webinars successful. Of course, ICOM and everyone behind the scene to conduct these webinars. Looking forward to seeing all of you in the next webinar, May 13. Thank you very much.
Alors.